In Canada, for the last decade, diagnosis and monitoring of myeloma and related disorder were aligned in almost all reference institutions with the International Myeloma Working Group guidelines. But in 2020, were released the Canadian guidelines written by Dr. Deborah Bergstrom and collaborators, representing the Myeloma Canada Research Network Consensus Guidelines Consortium and published in the Clinical Lymphoma, Myeloma and Leukemia Journal. A link will be provided at the end of this video to access the full publication. These Canadian guidelines are very close to the IMWG guidelines, but differ also in some details, and it is important to review some of the key points of these recommendations. The multiple myeloma evolves from a clinical silent state called monoclonal gammopathy of undetermined significance, or MGUS, through an intermediate stage termed smoldering multiple myeloma, SMM, associated with a high risk of progression to overt symptomatic disease requiring therapy. It is essential to determine where the patient is in the course of his disease to address the appropriate management with the appropriate physician. So the Canadian guidelines list and comment all laboratory analyses that should be performed at the initial diagnosis and for further investigation. So, multiple myeloma is defined as a disease with more than 10% bone marrow plasma cells or extramedullary plasmacytoma and one myeloma defining event. Myeloma defining event is a combination of CRAB and SLIM criteria. The CRAB criterion are associated to damage to organs, and CRAB is an acronym that stands for hypercalcemia, renal insufficiency, anemia, bone lesions. The guidelines clearly define the thresholds to assess hypercalcemia, renal insufficiency, anemia, and bone lesions. The SLIM criteria are associated to high risk to evolve to CRAB symptoms shortly and were considered as myeloma defining events. So the SLIM is also an acronym and represent three different parameters. So the presence of more than 60% of bone marrow plasma cells, first. Second, the serum free-light-chain ratio that is greater than 100 and measured by free-light-chain assay. And third is more than the presence of more than one focal lesion, at least of 5 millimeter, and measured by MRI. So also based on the initial assessment, if no myeloma defining event is detected, we can define the smoldering multiple myeloma as the presence of a serum monoclonal protein if it's a non-IgM protein greater than 30 grams per liter, or a urinary monoclonal protein if it's a IgM protein greater than 500 milligrams per 24 hours, and or the presence of 10 to 60% of bone marrow plasma cells. That's the definition of smoldering multiple myeloma according to these guidelines. Also, these guidelines define the MGUS as the presence of a serum protein, monoclonal protein lower than 30 grams per liter, and urinary monoclonal protein lower than 500 milligrams per 24 hours, and less than 10% bone marrow plasma cells. MGUS and smoldering multiple myeloma are by definition asymptomatic diseases, but these guidelines classify some subgroups based on biomarkers and characteristics that define a risk of evolution to multiple myeloma, and recommendation of monitoring are made accordingly. So for MGUS, there are three risk factors. The presence of a monoclonal protein that is a non-IgM protein, a monoclonal protein that is greater than 15 grams per liter, and an abnormal serum free-light-chain ratio that is measured by free-light-chain assay. These three risk factors stratify the MGUS in four groups. The low risk MGUS corresponds with the presence of no risk factor. The low intermediate risk MGUS is one risk factor, the high intermediate risk MGUS is two risk factors, and the high risk MGUS is the presence of three risk factors. And monitoring for MGUS is recommended 6 months after the initial diagnosis and every year after if the results are stable. Testing consists of complex blood count, calcium, serum protein electrophoresis, serum free light chain, and creatinine to monitor the hematologic, renal, and hepatic parameters. Bone marrow examination and imaging can be added to the low, intermediate, and high risk groups eventually. For smoldering multiple myeloma, the situation is a little bit more complex than MGUS because there are three prognostic models: the Mayo Clinic model, the Spanish group model, and the revised model that is known as the 2020 model. So the Canadian consensus guidelines consider that all models are valuable and recommend stratifying smoldering multiple myeloma according to the presence of the different risk factors validated in these three models. And it represents about 11 risk factors. And according to that, you have the high-risk smoldering multiple myeloma that is represented if you have more than 10% of bone marrow plasma cells and at least one risk factor. And the low and intermediate risk of smoldering myeloma are the risk where it's different for the high-risk smoldering multiple myeloma. So the monitoring of high-risk smoldering multiple myeloma is recommended 2-3 months after diagnosis and every 4-6 months for 5 years after if the results are stable, and then every 6 months. For the monitoring of low intermediate risk smoldering multiple myeloma is recommended 3 to 4 months after the diagnosis and every 6 months for life after if results are stable. I hope you find this video informative, and for more details, a free access to the full guidelines is available following this link.